Hi, I'm Dr. Deepak Megur, and let me take you through a case of a generalized zonular weakness in a case of pseudoexfoliation. These cases are very difficult to manage because the bag is not so loose that you need to sacrifice that. At the same time, the zonules will be very unhealthy and it's a progressive condition. So he is a 75-year-old gentleman who wants cataract surgery in this eye, and at the temp examination, the pupil is moderately dilating. This is the maximum dilatation which we can achieve. There is a very subtle evidence of phacodonosis. It's not marked, but the strength of zonules in these cases can be tested only when we puncture the anticapsule. So until then, it's extremely difficult to just imagine. Looking at the scenario of the pseudoexfoliation and the age, I'm expecting a compromised zonular weakness. Let us see how things turn out. So in this case, I'm going to demonstrate the IOL Trap Technique, wherein I'm going to use a multi-piece hydrophobic lens and place the haptics in the sulcus in the optic posterior to the rhexis margin. The first goal always is to take care of the pupil so that we expand the pupil, then we can manage other complexities as and when they come. So the incisions are created, the capsule is stained, and then I'm going to inject dispersive ovary to protect the corneal endothelium, and then time to insert the pupil expansion device, and a BHEX ring is my go-to device in most of my small pupil cases. So we have got all the notches engaging the pupillary margin, and we have got a dilatation of about 5.5 millimeter, which seems to be decent enough. Now, because some of the capsule escaped the staining, I'm attempting restaining the capsule using trypan blue. Although once the capsule has come in contact with OVD, it's very difficult to get itself stained, but nevertheless I thought something is better than nothing. Again, under the cover of OVD, the globe is stabilized with my second instrument. I'm going in with the capsular forceps and I just try to puncture it. We can see these radial folds emanating from the puncture site, suggesting that there is gross zonulopathy in these situations. The relatively blunt tip of the rhexis forceps will not work. I'm resorting to the 26 number needle to puncture the capsule. Even when the puncture is being made with a sharp needle, you can see the radial fold suggesting weak zonules. Once the flap is raised, the rest of the rhexis is being managed with the help of a capsular forceps. So in eyes with zonular weakness, the forceps gives us better tension and grip to tear these capsules. Now, to add to our problems, hydrodissection is difficult in these cases simply because the lax zonules don't provide any countertraction for the fluid way to pass across. So as you can see, I'm just trying to be very gentle and trying to push the fluid across the equator. It's not working. I'm going to attempt from another location. So a couple of attempts later, there seems to be some hint that the hydrodissection is completed. I'm trying to nudge the nucleus down and towards center to ensure that the cortical and the nucleus matter is truly separated from the capsular bag. So I inflate the chamber with OVD and then I'm going to use my lens hook just to ensure that whether the lens can be rotated. As was evident, the rotation of the nucleus was difficult. The bag is rotating along with the movement of the lens. So I thought this is the time for me to introduce the CTR, which is going to provide me 360 degrees stretch on the capsular bag and also act as an artificial zonules, providing some strength to the capsular bag as the nucleus manipulation is being done. So before that, I usually would like to aspirate some of the cortex so that there is space created within the bag. It's much more easier to insert the ring. Once a little bit of cortex is aspirated, I'm going to create some space under the rhexis margin by using sodium hyaluronate, and then the CTR, which is of the usual size, that is 11 to 13 millimeter, is being gently threaded into the capsular bag. I'm going to use the bimanual maneuver. So the second instrument is going to push the CTR to ensure that it doesn't stretch the rhexis margin. Now, with the capsular bag being well supported and stretched because of the CTR, I go ahead and repeat the hydrodissection, and the hydrodissection is much more effective now with the bag being in a stretched position. With the cannula itself, I nudge the nucleus down to see that it is free from its attachment to the bag. I proceed to emulsify the nucleus. The nucleus is relatively soft and easier to manage. The only thing is, during nucleus manipulation, we don't want to increase the zonular laxity. The bag is very floppy, and any maneuvering the nucleus is going to bring the bag towards the phaco port. So this is something which I need to be mindful of. The nucleus is being divided using the vertical sharp technique, and the first fragment is freed and pulled out of the bag and then emulsified in the antechamber. As the fragments are being emulsified, the underlying bag is wobbly and it's dancing around, as is very obvious. This is floppy bag syndrome. This is what I like to call these sorts of capsular bags. Carefully and very slowly, each of these fragments is gently manipulated out of the bag into the antechamber and then aspirated. Again, as the fragments are being emulsified, it's very clear to see the bag being very wobbly and dancing around. OVD is introduced again to pressurize the globe a little bit. So I'm avoiding nucleus rotation within the bag. Instead, I'm just using my lens hook to manipulate this soft heminucleus out of the bag into the antechamber for it to be aspirated. The last few fragments are emulsified and time to remove the cortex now. Removing the cortex in such a loose bag is probably the most difficult thing to do in this case. I'm going to use the tangential way of stripping the cortex, and I want to be as gentle as possible. But the moment we engage the cortex, the entire bag moves in. In these cases, because the laxity of the granules is such that we can never achieve a good cortical cleaving hydrodissection, the cortex tends to be very sticky to the capsular bag, and to add on, we also have a CTR inside. But nevertheless, if we are patient enough, and that's the only virtue to have, that's patience, we can tease out all of this cortex one by one. It's going to take a few more minutes, but that's worth it. So I'm going to use the IOL Trap Technique, wherein I'm going to place the haptics of the multi-piece lens into the sulcus, and the optic is then pushed back into the capsular excess margin. This has been my go-to technique in these eyes with generalized zonular weakness, and they have served me pretty well. I've been using them for the last 5-6 years, and thankfully until now, I haven't had a case where the lens is dropped back. Eventually it might, but hopefully the lens in the position outlives the life of the patient. Space is created under the iris and above the anterior capsule using cohesive OVD. The distal haptic is gently introduced into this space, and the proximal haptic is then dialed into the sulcus. With the OVD still inside, the BHEX expansion device is disengaged from the pupil and then removed. Now is the time to remove the OVD behind the lens. The lens is tilted up, and using the bimanual I&A, the cohesive OVD behind the lens is being aspirated out using the aspiration cannula under the lens. We need to be careful not to engage the posterior capsule during these maneuver. And once the OVD both in front and behind are removed, time to achieve the optic capture. With the irrigation in my left hand, the optic of the lens is gently tapped posteriorly so that it gets trapped in the rhexis margin. I'm going to use hook to retract the iris and to confirm the same. The ovalization of the rhexis is a sign that we have achieved optic capture. The wounds are hydrated, and that's it, the case is done. And these are the first day post-op pictures, and this is 1 week later. The patient continues to do well. How long will the lens stay? Well, it's difficult to say, but in these cases of generalized zonular weakness, this is my preferred go-to technique. Of course, in this eye, the laxity was quite severe, but I would prefer this technique more in eyes with moderate zonular weakness. And they have served me pretty well. The principle is you're going to use a CTR to provide 360 degrees support and stretch to the capsular bag, and then you're going to place the haptic in the sulcus, and the optic is being pushed back. It is basically, the principle is like that the lens is holding the bag rather than the other way around. Usually the capsular bag holds the lens and the CTR. In this case, we are hoping that the lens itself is going to support the bag for a longer duration of time. So this was a case where I was using IOL Trap Technique. And that's it. Thank you for watching and hope you found this helpful.